Good afternoon, everyone. Please give us a minute. We'll be starting shortly. Thank you. Could you kindly confirm if the online presenters are online? Not yet. You can sit. You can just sit there. The safety demonstration start with Mugodi. Mugodi. Sure, people are still trickling in. We'll be starting shortly. We cannot connect our online speakers. AVTU is just trying, but if they can't, we'll have to proceed without them. So kindly bear with us. Thank you. I don't think there's any session after us.
Yes.
So good afternoon, everyone, and welcome to this session, Management of Cervical Cancer in Women, living with HIV. So we've got two online speakers. Hopefully they'll be able to join. If they don't, I will have to do the needful and we'll get the session rolling. My name is Nyaradzom Godi. I'm from the UZ, University of Zimbabwe Clinical Trials Research Center, and my co-chair, she'll introduce herself.
Hi, everyone. My name is Makaita Gombe. I'm a TB HIV programmer with the Oram Institute in South Africa. Thank you.
Thank you, Makaita. So just to get, next slide, please, just to get this session going. Okay, I'm looking at the wrong slide. We know that to date, an estimated 20 million women are living with HIV across the globe, and we know that a majority of these are in sub-Saharan Africa. And we know that women living with HIV, their risk of getting cervical cancer is 4 to 5 times higher than women without HIV. Yeah, and we know that cervical cancer is a leading cause of death. Here in Zimbabwe, is the commonest cause of cancer death in women. Yeah. So only 20 to 40% of HIV infected women are screened for cervical cancer. And out of that 10 to 20%, less than 10% receive appropriate therapy. So there is an urgent need for robust cervical prevention programs in women living with HIV. And when we look at the healthcare provision, there are many, many, many missed opportunities for cervical cancer screening. We know that cervical cancer takes years to progress from CIN, cervical intraepithelial neoplasia, to cancer. So we've got 10, 15, 20 years for us to screen women, prevent cancer of the cervix. So we must really act timeously. And today we will hear about a lot in terms of what is being done to screen and vaccinate for HPV, screen for cancer of the cervix, and treat for cancer of the cervix. We will hear about the WHO strategy to eliminate cervical cancer, the targets that we must meet by 2030, the 90-70-90 targets in terms of who is vaccinated, what population. Dr. Kapambwe will talk more about this. So I've got three great speakers, if we are able to join them online. First and foremost, I've got Dr. Sharon Kapambwe, and I'm hoping, next slide, please. I'm hoping that AV, you are ready with Dr. Sharon's slides. After Dr. Sharon, we'll have Dr. Sabrina, who's dialing in from Uganda, and then Dr. Chinula, who's coming in from Malawi, will talk to us about management of cervical cancer in people living with HIV. And then I've got a special guest, Busi. She'll introduce herself. Since Friday last week, when we celebrated World AIDS Day, we've been talking about let communities lead, let communities lead. The other day, someone asked us, who is the community? What is the community? And when we talk about cancer of the cervix, I've brought the community to you guys to tell you what is cancer of the cervix from a Zimbabwean woman's point of view. So she will share with us a bit of her experiences as a survivor. And let's give her a hand before she introduces herself. But let's move on to Dr. Sabrina Kapambwe's slides. So, Sharon, Sabrina, sorry, Sharon.
Thank you. Thank you. I'm just trying to stand here because I tried to sit
To
there
see
in the morning and I kept switching my head and the slides were not moving. Can I have my slides, please?
So while they're sorting themselves out, Busi, can you tell us a bit about yourself, and we'll stop you when these guys are ready.
Okay, thank you. Um, Hello, everyone. My name is Busisiwe Moyo. I was diagnosed with cancer of the cervix in 2017. Apart from that, I'm a mom, a wife, a religious leader, a social sciences researcher. Yes, I always mention that just to show that there is more to me than just being somebody who was diagnosed with cancer. I presume I'll continue later. Thank you.
Okay, we good? Thank you. A very good afternoon to you all, and thank you for coming on a Friday at 3 p.m. It's so hard, but we are grateful that you came to another important session that we need to discuss. My name, as you've been told, I'm Dr. Sharon Kapambwe, WHO Technical Officer for Cancer Control. I'm based in Congo, Brazzaville. Prior to joining the WHO, I was working at the Ministry of Health Zambia, leading the cancer prevention program. Was also responsible for scaling up of the cervical cancer program in Zambia. So thank you. Next slide. So this is something that is close to my heart. So since I was told to speak about HPV-associated cancers among people living with HIV, we know that people living with HIV have a double-fold risk of high-risk HPV acquisition and the double-fold decreased risk of HPV clearance, meaning they get the HPV and the ability for their bodies to be able to clear the HPV that they acquire is very difficult. So they end up having what is known as persistent HPV infection, which can progress on, compared to individuals in the general population. HPV-associated diseases are major causes of morbidity and mortality, particularly in the sub-Saharan Africa. We know that cervical cancer, and that's why we're talking about it today, mostly cervical cancer represents 80% of the HPV attributable cancer we have. Okay, thank you. So women living with HIV are up to 6 times at an increased risk of having cervical cancer compared to women in the general population. And when we talk about other HPV related or associated cancers, we have anal cancer as well, which has a higher incidence in people living with HIV. And you can see that men having sex with men and having HIV have about 80 per 100,000 population person years. And then heterosexual men who are living with HIV equally have a higher risk of 32. And when we come and talk about women living with HIV, as far as anal cancer is concerned, it's about 22 per 100,000 person years. And then finally, men having sex with men but they have no HIV will have about 19, and men without HIV about 2. And so you see, and the increase, this risk increases with age. Therefore, you can see that if somebody is living with HIV, they are at a higher risk compared to the general population. And then we also find that anal genital warts in people living with HIV are more common. We see them a lot. And that's why when we talk about vaccination, we do want that, you know, the girls are also vaccinated against the HPV causing anal genital warts. Next slide. So the other cancers that you bring in, which I will not dwell in, we've talked about anal cancer, is really vulval and vaginal cancer. And I know that there's a study that was done in Zambia, and they have published an increase of seeing young women coming in with vulval cancer. And you see that vulval cancer will occur. Normally, what we know is that women who are postmenopausal, as in their 70s or 80s, so in the 7th or 8th decade. But we see that with women living with HIV, we see women coming in with vulval cancer, even at a much lower age of 40. So, and of course, further studies are needed to show the risk of women living with HIV. That's one of the things we have with most of the cancers. I know of the Zambian study. And there's also the issue of penile cancer in men that we see, which is also HPV related, ranging between 20 to 80% prevalence. But again, these are very few studies that have done that. So it is important to have studies where we can understand the interaction between HIV and penile cancer in our area. Next slide. So I already talked about this, the population attributable fraction of women with living with cervical cancer. This is 2018. And I said there are 6 times, increased risk of having cervical cancer versus those in the general population. But what we need to know is that they have a higher risk of getting HPV infection, and they have a lower chance of clearing the infection. Ideally, your bodies should be able to clear the HPV infection like any other viral infection, but those with HIV have lower chances. And then there's a faster progression from infection to cancer. So you will see that there was a study that I did among the women living with HIV where we saw women in the reproductive age who were coming with cervical cancer were also predominantly HIV positive. Lower regression of the precancer, that is when they have the abnormal cells on the cervix, they will not go back to a lower grade or indeed to be cleared, like we had said, and they have a higher recurrence following treatment. Like I said, younger at presentation. Next slide. So in 2018, we had a WHO call to action, and this call to action was made by the Director General of the WHO, Dr. Tedros, and this was a global. It was a WHO, the World Health Assembly 73.23, which is really a resolution which all the ministers who are coming from countries that are members of the WHO actually adopted. And this was a global strategy to accelerate the elimination of cancer of the cervix as a public health problem and its associated targets that were given. And that's what Dr. Nyirazo was talking about. So what are the targets? We're talking about elimination of cervical cancer. When we talk about elimination of cervical cancer, we're talking about a country having reached, that all countries reach less than 4 cases of cervical cancer per 100,000 person years of women. And what are the 2030 control targets? So what we're looking at is one, that 90% of the girls by the age of 15 are fully vaccinated with the HPV vaccine. And 70% of women are screened with a high performance test. Please note the high performance test by 35 and 45 years of age. And finally, that 90% of women with cervical disease are effectively treated or receive treatment and care. So that means that if I get abnormal cells, which are not yet cancer, out of the women that you're seeing, 90% of them should have received adequate treatment. If they have invasive cancer of the cervix, which is diagnosed, 90% should be that. When we say a high performance test, we're talking about women getting screened with a high performance test like HPV DNA testing, something that I know that we can have a discussion around. What we should know that finally, this will contribute to target 3.4, ensuring health and well-being for all. 33.3 reduction in mortality from NCDs. Next slide. Next slide. So starting with, we talked, because I focus more for the HIV population than the general population, but questions will be welcome afterwards, which are really dealing with everything. So if we focus on the girls living with HIV, new WHO recommendation on HPV vaccine schedules can optimize vaccine coverage. What we have noted is that currently, we have about 28 countries in the WHO African region, which has 47. So we still have about 20 countries that have not introduced HPV vaccine at a national level. So we have 28 that have introduced. So even though they have introduced, generally the coverage is around 21%. And remember, I said the target is 90% for us to be able to be on the way to elimination by 2030. WHO primary target for vaccination is 9 to 14 years of age girls, those adolescent girls. And it is recommended for those living with HIV, 2-dose schedule for all ages starting from 9 years old. Prioritize the vaccination of immunocompromised or HIV positive population that you target with at least 2 doses. I know that we have made a recommendation that 1 dose is effective for the general population, for the girls in the general population, but for the girls who are living with HIV, we're saying at least 2, ideally 3 doses. So that is what we had. The SAGE is our unit that looks into safety and efficacy of vaccines that have been used in WHO, and the review was done last year. Next slide. Okay, next slide. I have already pointed the next slide. When we come to the women, so we've said children living with HIV, the adolescent girls living with HIV, ideally 2 or 3 doses. When we come to the women recommendations for women living with HIV, priority screening starts from 25. The priority age, I don't want to say starts and ends, no. The priority age is 25 to 49. The general population will start at 30. So someone living with HIV by the age of 25 must start screening. For 50 to 65 who have never been screened, when tools are available to manage postmenopausal women. So if you're living in an area like most of the African countries where we have a high unscreened population of those who are 50 to 65 using the high performance tests like HPV DNA, they must be screened. Women living with HIV need to be tested more frequently than those who are not living when they have a positive test. So when they have a positive test, 12 months for women living with HIV. If you go and they tell you you're HPV positive, and then we need to retest you after 1 year. For those in the general population, we're doing it at 2 years. And once a woman, we said you need to be treated and you don't show up, if you come after 6 months, we will rescreen you and see you that you've never been treated because different changes could have taken place. So women who are pregnant, we defer to after pregnancy because there might be an effect if we go ahead and treat you. In circumstances when treatment is not provided, we reevaluate, like I said. Next slide. Next slide. Is that my last one? Oh, that's the last one. Okay, because I thought Lamek would take up the treatment. So I'll be available for any other questions that you might have. I was told strictly 6 slides, but I'm here to talk everything cervical cancer. Thank you.
Thank you so much, Sharon. Do we have Dr. Kitaka online? Not yet. What about Dr. Chinula? Not yet. So to kickstart the discussions, could we project Dr. Kitaka's slides? She took on from where Dr. Kapambwe has just left. Dr. Kapambwe has talked to us about the risk of HIV in HPV and vice versa, how the 2 viruses are symbiotic and how they have they affect how we're going to manage our patients. So as we project Dr. Kitaka slides, I'll maybe just whiz through them. She talks a lot about what Dr. Kapambwe has talked about. While we wait, Busi, anything else to share with us? Makaita, please feel free to pitch in while we wait for slides. Busi?
Thank you. I was just reflecting on the theme that is up there of ending inequalities, and just asking myself a number of questions on how this can be achieved to a woman like me who lives in a low resource country with so many challenges that that one has to address. When you get a diagnosis, cervical cancer diagnosis, the first thing that comes on is you having maybe two options: coming out of the woods and progressing with your life, or never making it. Should I continue?
Thank you. Makaita?
No, I think while we're waiting, one of the questions I wanted to ask was, so when you say high performance test and you say it's the HPV DNA, I know that there have been some advances in AI that's also used. Like, is that also still recommended? And what would be the plans for rollout of that if it is, given that it also uses software on a cell phone, for example? Does that increase equity?
So for the AI that is currently being used, that's still in study mode. It is not, we have to review, it's been done. I know that Zimbabwe, Zambia, I'm not sure, India was supposed to be one of the countries that we are doing. So what actually happened is when women go for visual inspection with acetic acid, which is our normal vinegar in our homes, in some of the countries, they do take a picture. And when they take that picture, they can store it like it's an atlas. So what the AI got was to have all these thousands and thousands, maybe we had reached millions of these atlas or cervigrams that had been saved, and try to study the morphology and program it together with the National Cancer Institute. So what happens is that when you take that picture, the AI starts making a diagnosis that this women most likely, based on the memories that have, the back end that has been filled in, that this women most likely has cancer of the cervix. But that, like I have said, is still in study mode. The results are being studied. So only after we find out, because we also have to be cognizant, the cervix of a woman who's living with HIV will be different to the cervix of a woman who's not living with HIV. We've got age that also makes our cervix look very different. It goes through many stages. The cervix goes through many changes throughout our lives based on infections or disease that could be prevailing. So that is under study. And if it does work, because then that becomes readily available. What has been modeled for the WHO global strategy is the HPV DNA, because remember we were using the VIA, VIA, which is the vinegar put on cotton swab and then left on a woman's cervix. The one you use for your salads, about 5%, left on a woman's cervix, and then we see what happens if they have abnormal cells because of the proliferation. You see that the cells are turning white. But that is a very subjective test. It depends on how competent the person who's taking, and also depends on how often. We can have somebody who's competent, but as long as you take a bit of time to be able to be doing this, because you get a lot of time. It was good in that you get the results instantly. We were able to screen many women, but when your model will not be able to eliminate cancer of the cervix using that modality. We needed a molecular test, which is much more objective. And the screening period in VIA, we were asking women to come back every year, and we check the cervix every year. But for women living with HIV, with HPV DNA, they come 3 to 5 years. And then for those who are not living with HIV, they come every 5 to 10 years. That means that we are increasing the gap and gives us more room to see more women who haven't been screened before. And that is very important. So what has been modeled, even when we talk about 2030, is that we want to get all the countries to reach 90, 70, and then they start now moving towards elimination. The only country so far that has been able to achieve 90, 70, 90 globally is Bhutan, which is one of the small countries in Middle East. They've been able, I think that's early this year, they were able to achieve the 90, 70, 90, which means now they are on a pathway. You have to sustain that 90, 70, 90 for some time for you to be able to reach the less than 4 per 100 women years of the population that you're looking at. So basically that's about the AI. It's still under the study and the results are being collated. Once we have, they'll be announced. And then WHO can only make a position once that has been found. Thank you.
So thank you very much for talking about AI. And I'm looking at colleagues in Zimbabwe. I think Prof. Chirenje, I don't know if there's anyone else. I think Zimbabwe is also looking, there are studies looking into AI for cervical cancer screening. So if there's anyone who'd like to come later on to talk about this during our discussion, please feel free to do so. So unfortunately, we cannot connect both Dr. Chinula and Dr. Kitaka, but Dr. Kitaka, sorry. Sorry. Okay, so I'll just whiz through Dr. Kitaka's slides. Next slide, please. She wanted to bring to our attention the rationale for HPV vaccination in people living with HIV. I'll skip this slide because Sharon here, she's really done a good job in terms of the double burden of HPV and HIV. Next slide, please. So already we'll also skip this slide because we heard from Dr. Kapambwe about the 3 pillars that are going to assist us in terms of achieving cervical elimination, global elimination of cervical cancer. She talked about vaccination, about screening, about treatment. So after this session, we need to remember the 90, 70, 90 targets and what we are doing to reach those targets. Let's skip the next slide. Already, next slide is talking about, next slide, please. 1 in 25 cancers worldwide are linked to HPV. I will not belabor this point because Dr. Kapambwe, could I please send someone to go next door and ask the participants there to keep it a bit low so that we are able to concentrate here. So we know that HPV is a significant global health burden with infections of at least 1 person per minute who is diagnosed with a certain HPV-related cancer each year. Next slide, please. And we've heard about this. The areas where there's high prevalence of HIV are also the areas of high rates of HPV. If we could superimpose these maps, you'd see that they really where there's high HIV, there's also high HPV because the modes of transmission is the same and these are symbiotic viruses. Next slide, please. We heard from Dr. Kapambwe in terms of HPV and HIV interaction. These are symbiotic, I keep on repeating, these are symbiotic viruses. In HIV-infected people, the persistence, the clearance, higher persistence, lower clearance of HPV. Women living with HIV are 6 times more likely to develop cervical cancer. We talked about that before. Next slide, please. And the HPV types which are causing cervical cancers in women living with HIV, 67% of the cancers are due to HPV 16 and 18, and then HPV types which contain which are 90 0.3% HPV types contained in the nanovalent HPV vaccine. Next slide, please. Here she just wanted to reassure people, listeners, of the safety and immunogenicity and efficacy of HPV vaccination in people living with HIV. Next slide. So she talks about this study. This was a meta-analysis of 24 studies, which included 7,500 participants. And this analysis suggests that HPV vaccine is safe and efficacious in people living with HIV. Next slide, please. I will skip this next slide. We've heard about the safety of HPV vaccination in children. We've already heard about this. Immunogenicity, next slide. Long-term immunogenicity in adolescent girls and boys living with HIV in Kenya. The findings from this study is that the sustained HPV seropositivity and GMT levels gives reassurance of possible long-term efficacy of vaccination and sustained protection from HPV-related morbidities. Next slide, please. We'll skip, next slide. Could you go on to the next slide? Slide number 15. So, next slide, please. So why, next one. These are just demographics of a study that she did. So this is a study which Dr. Kitaka and team, they looked at the barriers of HPV uptake. So there were major themes that came from their study. The major theme, for example, there was the relationships. Parents do not approve of it or don't stay with the children. So already we are seeing the barriers. Earlier on, Busi talked about the barriers in terms of treatment of cancer of the cervix, but already there are barriers to HPV vaccination. There were also barriers associated with healthcare. Okay, maybe I jumped. So the individual, there is inadequate knowledge, information about HPV. So we need to create demand for HPV vaccination. There's also fear of side effects. We need to address the side effects so that the uptake of HPV vaccination is good. Next slide. So I'd already started about parents not approving of it and healthcare services where HPV vaccines are not available in hospitals. I think this is a variable in terms of the regions. I would like to believe that we have HPV vaccines readily available here in Zimbabwe. Next slide, please. So in summary, in terms of immunogenicity and safety of HPV vaccine in people living with HIV, there are high rates of seroconversions which have been observed in HIV-infected individuals across age groups. There is some evidence of lower GMTs in HIV-infected versus HIV-uninfected individuals. The clinical significance of this is not known. ART might improve vaccine immunogenicity. So already vaccination and ART, they are working in a symbiotic relationship. Children and adolescents with HIV should be vaccinated when they have low HIV viral load and high CD4 counts and prior to sexual debut for optimal response. Dr. Kapambwe has talked about this. HPV vaccines are generally well tolerated among HIV-infected individuals. Next slide, please. So WHO recommendations, I think we've heard about this. People living with HIV, regardless of age or antiretroviral therapy status, should receive at least 2 HPV vaccine doses, minimum 6 months interval. So Dr. Sharon has talked about some of this, and we can go into it during discussion. So we also have US and European recommendations for HPV. Next slide. For HPV vaccination, I will not dwell much upon that. And then developing countries, next slide, HPV vaccination in people living with HIV. HPV vaccination and testing, especially for HIV-infected women, should be a priority in developing countries based on plans for the United Nations 2030 Sustainable Development Goals to reduce non-communicable disease mortality. Next slide. Next slide, please, the summary. Can you just continue? I want to go to the next slide, the building synergies. So, given the association between HPV and HIV, synergies must be leveraged and a focused and integrated approach to saving women's lives must be taken. Synergies between the HIV response and efforts to prevent, diagnose, and treat cervical cancer through HPV vaccination, education, screening, and treatment must be maximized. Next slide, please. I think that's the end. So we must deal with this double burden. We must reduce the HPV and HIV, a double burden. So thank you for listening to me as I whisked through Dr. Kitaka's presentation. So Dr. Kapangwe, half a minute. What are your comments from this presentation as we get the last presentation and we can get into discussion?
I think in a minute is just to say that adolescent girls living with HIV must be vaccinated with the HPV vaccine, and they must receive at least 2 or 3 doses according to the research that we have. Of course, there has been a recommendation for the other girls in the general population to receive 1 dose. I think what I would love to hear is, because most countries have had the difficulty of distributing this second dose or third dose to the girls who are living with HIV, because the general population, and remember, these are now small numbers with the elimination of mother-to-child transmission that we've had. Now we're getting fewer and fewer girls who were born with HIV. So to find them is easy, but to be able to receive that dose has to be done systematically. So today, I think it would be important for us to learn maybe from countries if they've been able to implement that. Some countries are just implementing according to what Gavi gives them, according to the vaccines they give. So I've seen some colleagues who are running programs who can give us some ideas of what they're doing. Thank you.
Thank you very much for that. I'm going to put it to the floor. I understand we have a few minutes left. If there are any questions to probe on the diagnosis, the treatment, any access issues. I see a question at the back.
Yes, so thank you, Uncle Mike, and thanks, Mike. So I think we should also just flight Dr. Chinola's slides. He talks about the management, but Prof. Chirenge, please come through and tell us the programs in Zim.
No, so sorry, I need to go somewhere else, but can I please, thanks for the panel, excellent discussions. Can I please have the Sharon slide on the WHO elimination plan? There could be some program people here that it's critically important to know the first pillar for HPV vaccine. I don't know if you can push on that slide. I'm going to talk from a programmatic point of view. I was asked to give a talk at Bill Melinda Gates, joint WHO and Bill Melinda Gates Foundation. And so I wanted to comment at program level why a country like Zimbabwe, you pointed to 20% vaccination coverage. So I was chair for the Zimbabwe HPV vaccine program, which we did demonstration program. In Zimbabwe, coverage is 80% and above. I want to emphasize that in terms of those, okay, you see the first pillar there? If you do modeling for Zimbabwe, you gain much, much more by that first pillar in the next 30 years. I want to emphasize that, okay? If you look at the second pillar for most Southern Africa countries, I gave that presentation. In terms of screening, you are lucky to get a 20% rate of women who are coming for screening. In Zimbabwe, it's about 18%, okay? Whereas the vaccination is 80%, okay? So you get your coverage much, much better. In some countries, it's 0, that middle one. Talk about the last one there in treatment. We have data for women who are coming for screening, 50% of them not coming back for the screening, which is scheduled to be treated by lip or cryotherapy or thermal ablation. So those two, they look very nice, but actually they are very difficult in program level to achieve. So we must really push our countries. These girls who are young are in school. That's the success for Zimbabwe. It's because we do a school-based program, and it's just, it gives you so much gain. So thank you for elaborating on that. But when we go back home, if we're going to achieve something, push those girls to be vaccinated. I'm not ignoring the ones who are HIV. And then the one I want to also to just point out is when I give lectures to medical students on cervical cancer, the appalling thing for a woman, thanks for coming up, in our clinic in gynecological cancer in